Hi, I'm Matt Collins, and today I'm going to be performing needle decompression and decompression of a tension using a pneumocath and showing the skill of finger thoracostomy also. So for needle decompression, I've got this ARS air release system cannula that I'll be using for needle thoracostomy. It's a sharps out. It's a 10 gauge cannula. It's about 8.5 centimeters in length, which is longer than the 14 gauges that we used to use for these. So for my anatomical landmarks, I'm going to be using this nice rack of ribs here. Obviously it's not the same width as a human being. So I've got the sternal margin down through the middle here, and then obviously your clavicle out here to your AC joint, and I'd be finding my mid-clavicular line. So I'd be from here out to my AC joint up here. So find my substernal notch, come down, find the angle of Louis, and walk out and find the second rib, which runs out from your angle of Louis, and just below that is my second intercostal space. And then I walk out along my clavicle and find my mid-clavicular line, and I make my way down, and there's my anatomical landmark. So for this demonstration on these ribs, we're going to say this is the mid-clavicular line just here. So I'm going to grab my ARS, sharps out, got my sharps container already set up, and I'm going to swab the area, just like so. So what I do, I've got my landmarks marked out. I'm going to go at 90 degrees to the skin and angled towards the vertebral body. I'm going to advance it in until I go through. So I'm advancing just above the third rib to avoid the neurovascular bundle, which is below the second rib. As I go through, get through, and then I can advance the sheath through, sharps out, and secure it with some tegaderms, just like so. And with the ARSs, because they're such a big size cannula, they have a high likelihood of biopsying the chest wall and muscle as you go through. So just something worthwhile doing after you've done it is just to flush it with some normal saline to clear the line. So for my next decompression, I'm going to be using my Arrow Pneumocath set, and I'm going to be using the rack of ribs that I used previously for the ARS. So first I prepare all my equipment, and I grab my tubing, I grab my lure lock, and I attach it to the right end, making sure it's in the open position. And I grab my blue latex tubing and I attach it to that end, and then makes it simple, blue to blue, but this is also a one-way valve, so air will only go in one way in this direction. So I attach that to that like so as well, and that's ready also. And now I've got my needle here, so sharps out. I grab my 5mm syringe and I fill it with between 2 and 4 mils of normal saline, and I attach it to the needle hub like so. And I have that prepared. I've also got some tegaderms here ready to go for when I secure it. So my anatomical land site, so I go second intercostal space above the third rib, avoiding the neurovascular bundle underneath the second rib, same as using the ARS. So I grab my swab, and I swab the area, and then scalpel. Thank you. So scalpels are sharp out, take the protective coating off it. I make a small incision in the chest wall. Now if this person was conscious, I would use some lignocaine for some local anaesthetic, but my ribcage here is unconscious. So sharps away. I grab my needle and I pull the needle guard up, halfway up the cannula. And from here, I place it 90 degrees to the chest wall, angled at the vertebral body, and I advance the cannula until I can freely aspirate air through the cannula like so. And I advance it 1 more centimetre, then I remove the needle guard like so, and then I can pull out my needle, saying sharps out as it comes out, and put it away in a sharps container. And I advance this cannula to make sure there's at least 5 centimeters left of it here. From here, I grab my lower lock, and I can attach it like so. Just rest that there. And then with my tegaderms, I secure in place. Like so. And then I'd secure the Heimlich valve to the patient's chest wall. And then once I've secured all my equipment in, I can look for the flutter of this Heimlich valve to observe air coming out through the Heimlich valve. And for another option for decompression for tension pneumothorax is finger thoracostomy, which is a skill that the HEMS mica dudes are able to perform. So for this, anatomical landmarks for this, I need to find the lateral. I'm going to be using these rack and ribs again as for my demonstration. So for anatomical landmarks, find the lateral border of the pectoralis major, and then the anterior border of the latimus dorsi, and then I find my axilla. And then from here for males, I find from the at the level of the nipples or the mammary fold in females, and that from all those margins, that makes an area of safety, a triangle area of safety, that for when you make your incision, that's what you want to be in. So you get the patient to adduct their arm to 90 degrees, so have them lying down flat and have their arm back over their head, so you have good access to it. So once I've got my area of safety, I grab my gauze and everything, which is covered in betadine. I betadine the whole area. And then with some drapes, if I had some, I'd place it over the chest wall with the opening just here over the mark of where my incision is going to be. With my scalpel, grab my scalpel out, and I'm within my area of safety. Find the 4th or /5th intercostal space. Now I pinch, and when I make my incision obliquely running with the rib, so not up and down, but kind of sideways in layman's terms. And I make my incision about 30 to 40 mil through the subcut tissue, and then finish with my scalpel out, sharps away in the sharps container. Then with my other hand, with my forceps and my finger on top of it, through the incision that I've made, I'll push through until I push through the intercostal muscles and into the pleura. And once I feel I'm in, I can withdraw my forceps, and I've made a hole big enough that I'm able to do a finger sweep. And from here, I'm able to feel for the actual lung to see if it's inflated or to see if it is actually decompressed.